So any questions from yesterday? Anything we covered there? I'm gonna finish this section up and then move into the endo section, just because I want to make sure we have enough time for review towards the end there. So I will probably use all the time today, which is all right. I was just reminded of a funny kid story since today is Peds Day. So it'll be the best birth control or the worst birth control, depending on your state of mind. But I had this one patient who was consulted on. It was at Nemours, and this patient had some sort of exposure, and the kid was like probably like 7 or 8, but just really was just not really with it, right? He was just really just not communicating appropriately, just answering everything inappropriately, and just not making sense. So I came up to see if there's any kind of like drug exposure, maybe like amphetamines. The kid had history of ADHD. Oh my goodness. I hate when computers start acting on their own. The revolution starts now. No, but I had this patient, so I was consulted to see if there's any kind of like drug exposure. It could be, related back to the patient's, just mental status issues. And so anyways, I went in to talk to him, and of course he's like just, typical like 7 or 8 year old, just not really just paying a whole lot of attention to the adults in the room. And I was trying to get a history and all this kind of stuff. And then eventually he said something about like Dom Mazzetti or something like that. And I was just like, that name's really familiar. Where do I know that name from? And I was like, Fast and the Furious. And I look at him, he's like, you know what I do? I like to live my life 1/4 mile at a time. And immediately he just like, his eyes lit up and he's just like, oh, this guy gets me. I was able to have a full conversation with him after that point. So sometimes you just need a good jumping off point with these children in order to have a good conversation with them. I would recommend Fortnite, as that tends to be pretty, ask them if they like to maybe floss. I'm sure you'll see a lot of that today, which is something to think about. Anyway. That's not for your teeth, right? So let's finish up the surgery section. I'm hip with the kids. I still stay up on memes. I don't know what's going on. No, I was kidding. Anyway, so we were talking about sedation meds, and we had this term we call conscious sedation. What do you think that means? You were sedating them and they're still conscious. Yeah, essentially that's what the name means, right? So they're not going to be completely conscious, as the case may be, but you're using these kind of graded levels of sedation. Yeah, this kind of graded levels of sedation to where you don't want the patient to be under, necessarily general anesthesia, right? Because that's where you start thinking about things like ventilatory support for the patient. But basically what you're doing is alleviating that anxiety and pain associated with whatever procedure you're having to do there, right? So maybe combining sedative medications that will helping with anxiolysis and trying to chill them out a little bit. Like what kind of meds would be good for that? Benzodiazepines are really good for that, right? So you're a little bit of midazolam might be a good option, either oral, intranasal, IV, something like that. And then usually a pain medication, which could fall in which category? Typically an opioid, right? So we might do a little bit of morphine, might do a little bit of fentanyl, whatever the case may be. Very frequently, especially for kids, like we have them coming in and they're very like needle phobic and we're having a hard time getting an IV started, we might do intranasal Versed to try to chill them out, get the IV going, then we can do a dose like fentanyl. Just depends on what the situation is and kind of what they really need there. Other things we're going to see with conscious sedation is that they need to retain their own patent airway. So we're expecting the patient to be able to protect their airway. They're going to be breathing on their own. We're still going to be monitoring for that because you may find that these conscious sedations may slip down the rabbit hole, so to speak, and they can become more sedated, may start to lose some of that respiratory drive, and then we need to support them, right? So we generally always have like an RT available, a respiratory therapist available to help out, make sure they're monitoring that sort of thing. When you start to get to these deeper levels of sedation, so especially if you're like starting to reduce fractures and things like that, we'll get into drugs like propofol and ketamine. And who do we say ketamine is good for? Why is it good for kids? Not mainly, or I guess who is it bad for is a better question. Adults, why? Those dysphoric reactions they can have. Now, that doesn't mean you can't give ketamine to an adult patient. It just means you have to be careful and just know that that dysphoric reaction can happen. And that's usually when they're coming out of it and they'll start to get a little aggressive, a little anxious. It can be pretty troublesome. But again, how would you treat that dysphoria? To give them some more benzos, right? Just try to chill them out from that standpoint. So again, we can always treat it, but we always like to not to treat side effects of one drug with another drug if possible, but sometimes you have to, depending on the case there. So anyways, just be aware of the fact that for reversal agents, we only have stuff for benzos, and the opioids, obviously for opioids, the reversal agent is naloxone or Narcan, and then how about for benzos? Flumazenil or Ramazicon is the brand name there, right? Which one's more dangerous? Flumazenil, right? Who's that dangerous in? People are chronically on those benzodiazepines, right? Because again, if you reverse that and you put them into withdrawal, you see that excess excitation, and you can see potentially seizures, right? Which can be deadly. So. Looking at, say, conscious sedation, say, in different settings. So, for instance, the intensive care unit. So sometimes you have to have these procedures being done. Either maybe you're starting up like an arterial line, maybe you're doing bronchoscopy, maybe all kinds of different things there. It's occasionally required, but remember when you have these patients in the critical care setting, they're obviously going to be much more physiologically stressed than, say, someone else, say, just in the normal med surg kind of floor there. A lot of times they maybe also be require mechanical ventilation for like really prolonged periods of time. Some people may be on the vent for weeks, if not months, potentially, right? And so you have to think about concomitant infections they may be getting from that. You have to think about all the medications they're on. You know, they may be on long-term sedatives like propofol, like benzodiazepines, like opioids, all that to keep them on the ventilator. So you have to kind of think about those combinations there. And so very frequently we're going to use combinations. We may use things like low doses of IV anesthetics. We may use neuromuscular blocking agents. Right, those are our paralytics. Those are things we're going to talk about a little bit later on when we get to the emergency medicine section. What do you think? What's the benefit of using a neuromuscular blocker for like procedures? Yeah, they're not going to be moving on you, right? You're paralyzing the patient, so they'll have no muscular contractions going on. They're going to be very, very loose, so you can kind of do whatever you need to do for the patient. They're also not going to be fighting you at all, right? It's very, very important. If you ever give a paralytic, what do you have to give along with it? You just want to give like a paralytic to a patient who's fully conscious? No, that's very, very bad, right? You have to make sure you're giving a sedative or something beforehand, make sure they are not conscious for that period there. And whenever they'll have like sleep paralysis or wake up and like your body can't move, like it's pretty terrifying, right? And so there's cases of people who undergo surgery and they're like, no, I was conscious for the whole thing. A little scary, right? So you don't want to do that. So you always want to make sure your patient is well sedated prior to getting a neuromuscular blocker. And we'll talk much more about those later on, but just something to think about. And then also we have dexmedetomidine, or Presidex is a newer drug that we're starting to use, which we'll talk about right now. So Presidex, actually, you already know a lot about Presidex because you know a drug that works exactly like Presidex. And so this is an alpha-2 agonist. So what other drug do we know that acts as an alpha-2 agonist? Clonidine. What else? We used it for ADHD. Glomphosine, yep. Glomphosine is the other one that's the alpha-2 agonist, right? And so if you remember, it's a sympatholytic. And if you remember the side effects of clonidine, you'll know what the side effects of Presidex are, right? So you're going to see things like sedation, which is what we're using it for. You're going to see things like decrease in heart rate and blood pressure. And so this is a very short-acting agent. We're using it as an IV continuous infusion to try to calm the patient down. And if you're thinking about things like in terms of how sedating a drug is, you think about propofol, and I can make a person completely fully unconscious with propofol. This is pretty minor. This is like, almost like, you know, comparing, say, codeine to like hydromorphone, right? So again, this is pretty weak, but it can be useful if you just need kind of a light sedation for the patient, right? Or if you're trying to tamp down some of these, you know, get the blood pressure and heart rate down a little bit, try to calm them down from that standpoint. This could be a good option. So, for instance, we use this quite frequently for our you know, post-op cardiac kids, right? So again, they may be still ventilated, they may still be on sedatives. We'll also put them on Presidex to try to keep the heart rate and blood pressure under control, to make sure they're not kind of stressing the system too much after they've had open heart surgery, essentially. And so again, very short acting, which makes it good for titration, right? Like short acting medications, because they get to steady state that much faster, right? And just be aware of this hypotension bradycardia can be seen with high doses there, okay? More deep sedation, right? This is going to be cases where patient is not going to be easily aroused, right? So again, they're not going to respond to painful stimuli potentially, depending on how deep down you go on that pathway. And again, a lot of these cases, they may not be able to maintain that patent airway. So this is where you need to support them, either with back valve masks, maybe need to intubate the patient, whatever the case may be there. You have to keep in mind that it's hard to distinguish, you know, deep sedation versus full-on IV anesthesia, right, where they actually are fully under general anesthesia at that point. So, you know, monitor the vital signs, look for different things that may kind of distinguish between the two, but it can be pretty tough. To get to this point, this is where you're going to need things like bigger doses of ketamine, propofol, opioids, benzos, all of that. Notice here that you can use the same meds for conscious sedation versus deep sedation, but what do you think is the big difference between these same meds being used in these different cases? What's the difference? the dose is going to be a lot bigger for these deep sedation, right? So again, all has to go back to the dose. And it's very easy for someone who you think you're doing a conscious sedation on, you give them maybe a little too much for them, maybe you didn't anticipate how well they respond to it, and they move into more of a moderate to deep sedation. And that's important because then your monitoring is going to become much more intensive. You have to make sure that airway is going to be remain patent. And so looking at your choice of anesthetics, it depends on the type of procedure you're going to be doing, you know, the location, all those sorts of things. Remember thinking about if we can just get away with local anesthesia, that can be a very nice option there. We're talking about those nerve blocks and epidurals can be beneficial, right? So especially for like someone going into labor, about to have a baby, you don't want them up the entire body, right? You don't need that person. You still want that person to be conscious and with it so that way they can push, they can be cooperative with you to get that baby out, right? Think about things like the patient's age, the condition, previous experiences with anesthesia. You always want to ask about what have they received in the past and how they responded to it, right? So for instance, if someone's like, oh yeah, every time, you know, I got a dose of Versed one time before surgery and I got super loopy and super agitated and it wasn't good. You know that they may have a paradoxical reaction to that. You need to be aware of that sort of thing, okay? Someone had a paradoxical reaction to a benzo, how could I treat that? You give more benzo, right? Eventually you kind of flood the system and you shut kind of everything down to a point where they will not be so agitated anymore. But make sure equipment is available if you need it. So for instance, if we're doing say like a moderate sedation in the ER, say we're reducing a fracture and we're not anticipating the patient to lose their airway, but we have the RT in the room, they're monitoring the patient from the head of the bed, they're looking at end-tidal capnography, they're looking at all this sort of stuff. Where do you think the intubation equipment is? Right behind the RT, right? Because we have to be ready just in case that patient slips down, they lose their airway. We need to be ready to intubate if need be, right? So you have to make sure equipment's available. And again, a lot of it is dependent on the anesthesiologist you're working with, the CRNA, whoever's performing the actual anesthesia, and the patient themselves. If it's in the ER setting, it'll probably be like the ER attending who's doing that. Just depends on kind of where you're at, what your setting is. Other adjunctive agents, again, we mentioned benzos are good for helping to control anxiety. Usually it's like a pre-op sort of medication there. They'll facilitate amnesia, especially that anterograde amnesia, so they don't remember new events that are happening prior to going to surgery. Barbiturates are good for sedation, as we mentioned. And then we have things like antihistamines that are good for maybe prevention of allergic reactions, right? So again, if they are getting opioids and they start to get kind of flushed and a little itchy, we can give them some antihistamines there. Antihistamines, especially the H1 blockers, what big side effect you normally see with those? Sedation, right? Your first generation agent. So again, these are just the first generations we're talking about. It's not like you're not going to give Zyrtec or someone in the surgery sort of setting there. But certainly Benadryl, like IV Benadryl, you can use. So that sedation can also actually be helpful, right? That can actually help along with some of the amnestic properties of things like benzos can kind of help with, with that little bit deeper level sedation. And in fact, they used to use anticholinergics along with things like benzodiazepines to induce what we call like a twilight sleep. So if you ever hear like scopolamine being used along with something like a benzo, that was to help with the amnestic sort of properties there. Zantac can be used to help reduce gastric acidity. This is not used as commonly, just something you may see occasionally. Zofran is going to be used a lot, especially kind of prophylactically because we know that when patients are waking up, they may be more likely to have nausea and vomiting, but they may not be protecting their airway super well. So that's going to be important there. Obviously, opioids are good for analgesia, and as I said, the anticholinergics are good for that amnesia. Also, what kind of effects do the anticholinergics have? They're going to dry you out, right? Which can be good because if you have increased secretions, that can affect the airway, right? So you may want to go ahead and use an anticholinergic to try to help dry them out from that standpoint, right? Like a pyrrolate's fine, antihistamines, as we mentioned, the first generation H1 blockers would be helpful with that as well. So a lot of different cases where you may be using those. We'll talk about paralytics a little bit later and how we can reverse those, but that'll be important when we're talking about anticholinergics there, so kind of keep that in the back of your mind for when we get to the ER section later. Okay, so that's it for sedation specifically. Any questions on that? How we use sedatives, when you might use one agent versus another, anything like that? Any good sedation stories you've had personally? I'm just kidding, I don't need to know that. But oftentimes whenever we're giving ketamine to kids, I always like to tell the parents, like, listen, if there's anything you want to know about the child, any questions you want to ask them, after the procedure when they start to wake up is the time to ask. Because that stuff acts like truth serum, right? So they'll basically tell you whatever you want to hear. You got a girlfriend? Yeah. Dating Jill, blah, blah, not that I advocate invading a patient's privacy from that standpoint, but I'm just saying they're going to be loopy, they're going to be talking anyway, might as well kind of direct that a little bit. Again, I hope my children never listen to this, because Okay. So let's talk about local anesthetics. So what are some agents you think we're going to cover in this section here? Lidocaine's a good one. Bupivacaine. Yeah, so all the canes, right? We're talking about the canes here. So again, nociception is, we kind of know how these work already. We've alluded to it. We know they're being mediated through these nociceptive fibers here. And we're going to interrupt this and try to block that sensation by doing what? Yeah, we're going to block the sodium channel, right? We're going to block the propagation of the action potential. And again, which kind of nociceptive fibers are firing more quickly or more frequently? The ones that are kind of dormant and not active, or the ones that are actively in pain? Probably the ones that are actively in pain, right? They're firing more frequently. So you're actually going to find that local anesthetics are going to preferentially bind to those because they need to have those sodium channels open to actually get into them and actually inactivate them, as we'll see there. So they work very well for helping to deaden those effects there. And again, we can work on other steps of the pathway, right? So those pain signals, if they maybe make it to the spinal cord, we know that our opioids work there to really blunt that perception of pain. They can work more centrally as well, right? When we see our general anesthetics working there to basically, decrease consciousness so you're not even aware of the pain. So different steps there, but by using local anesthetics at the site of the injury itself, it's good because one's acting locally, so you're limiting some of the systemic side effects, and it can be nice because it will limit the amount of systemic other drugs you need to administer, like opioids and benzos, etc. So looking at this, we're going to try to use this reversible blockade of that impulse conduction, right? For blocking those sodium channels to prevent the signals from transmitting up to the spinal cord. And we know what the first anesthetic was we ever had, the local anesthetic? It's cocaine, right? So cocaine, anyone know where it comes from? The coca plant, right? We get from South America, and so we realized that this is actually a very good drug as an anesthetic because it blocks some of the sodium channels. Now, if you ever watch any crime dramas or TV shows where they test for to see if something is cocaine or not, what do? Rub it on their gums, right? Why do they do that? That's an anesthetic. If it numbs up your gums, then you know that it's cocaine. Is that always the case? Not necessarily. Sometimes you actually can spike it with something like benzocaine. If you were maybe trying to get away with selling less cocaine than you actually were purporting that it is, you can actually use some benzocaine in there, and that will actually do the same thing. Not that I would advocate for that, right? So I say customer service first always. But yeah, so cocaine's been around for a good long time. We'll talk about some other benefits of cocaine as well. Namely, you can study more, you can stay up. In terms of surgery, the benefits of cocaine are going to be numerous, as we'll see in just a second. And actually, initially when we opened up, we actually carried some cocaine at the Children's Hospital, which you're like, that seems a little crazy, but we ended up not using it, so we ended up expiring and got rid of it. But and just be aware of that it's when you're looking at the toxic effects of these local anesthetics, it's basically an extension of the therapeutic effect. So it's difficult to determine when they're really developing toxicity or not. We'll talk about some ways to look for that. So as I mentioned, the mechanism here, they're blocking the sodium channels, preventing that propagation of those signals up to the spinal cord and eventually to the brain. And we're going to find that this should be a reversible process because obviously you want them to dissociate eventually because you don't want that tissue to be numbed up forever, right? So that's really a big thing we're going to see with that. So as I mentioned, cocaine is going to be kind of the first one we had there. Again, here's some examples of what this would look like either in the plant form or eventually when it's finally rendered down. Now again, when you're looking at cocaine, how's it normally used? You can use it intranasally, right? What's the fancy term for intranasal use of cocaine? Insufflation, right? It sounds like a fancy French dessert or something, but it's insufflation. What are some other ways you can use it? So interesting. So in considering when you're smoking it, that's not actually cocaine. That's actually going to be the freebase form of it. So that's crack cocaine when you get to that point, right? So otherwise, regular cocaine hydrochloride actually pyrolyzes if you heat it up. So you cannot smoke that form, right? It's good for IV injection, good for snorting. But if you actually get to the crack form, when you freebase it, is when you will have it available to smoke. That's important. I only mention that because of the fact that that can dictate what kind of effects you might be seeing from that. So for instance, which formulation of cocaine do you think has the fastest onset? It's actually the smoked form, right? Because if you think about the pathway, how it gets into the system from the lungs, where does it go to next? It's the left side of the heart, and then it goes where? Straight to the brain, right? Versus if it's IV, it has to go through the whole venous system, it has to eventually get through the lungs, eventually get to the brain. If I were to snort it, again, it has to get absorbed through the nasal mucosa, again, go through the venous system, right? So these are things you have to consider, like, what's the duration of action and all of that. It can go into, based off of how they administered it, right? What the actual route of administration was. Okay, so that was our first one we had for a while there. Some other properties that make it good as an anesthetic for like surgical use. We have other things like prilocaine, mepivacaine, ropivacaine, bupivacaine, and lidocaine. I'll probably say these last three are the most common ones that I run into from a clinical use sort of standpoint there. Lidocaine is probably just far and away the most common one. We have a lot of different dosage forms for this. We have things like viscous lidocaine that we can use for like oral use. We have things like lidoderm patches that we can use for things like neuropathic pain. We've kind of mentioned lidocaine several times before. We might use it in the cardiac unit. So like ventricular arrhythmias, especially after like an MI. If you remember, lidocaine's what kind of antiarrhythmic? 1B, right? Remember 1B, those were better for getting into ischemic tissue than was, say, normal tissue, right? Normal functioning tissue. But anyway, so these are some representative examples of local anesthetics. Usually if you see a cane on the end of it, you know it's going to be an anesthetic. So what are the differences between all of these? And don't memorize this slide by any means, but looking at it, you can see things like, the half-life elimination can be very different between these different agents here, which may lead you to choosing one versus another. So for instance, I'll give you a good clinical example. We have, when we were first opening up the hospital, and we were kind of getting set up from the ER standpoint, we were starting a program. And if you ever go to an wards, you'll see we have like the boo-boo care team, which is basically a group of paramedics who do all of our sutures there in the ER when they're there, right? So that way, if you have a kid who comes in with a laceration, you, the provider, can be freed up to go see more patients while they're actually doing the suturing itself, right? And so for a while, we're trying to come up with protocols and what drugs to use, et cetera. And so the general sort of common thing we would do is just numb up the area with lidocaine, right? You do local infiltration around the laceration to numb up the area so you can do your suturing. So we use lidocaine. Well, we had someone who was an expert at it. He'd come from a different hospital, and he's like, no, we want to use bupivacaine. Why do you think we'd want to use bupivacaine over lidocaine based off of this? Lasts longer, right? Why is that important? That way when you suture up that laceration, kid goes home, they're still numbed up for a good long time, right? So you may actually find that because you're injecting it locally, it's not really getting absorbed systemically, you're going to find it has much longer duration of action than just what the half-life is. So that kid may be numbed up on the area for, say, day and a half or something. What implications does that have for other medications they may need?
So the other medications kick in. Is that the idea?
Not necessarily as a bridge, but it may mean they need less other medications, right? They may need fewer analgesics. If the area's numbed up and they're not experiencing any pain, they may not need things like an opioid prescription, right? They may not need things like NSAIDs or Tylenol and things like that to deal with the pain because they're just not sensing it. So that can be a benefit there, right? So by using a longer-acting medication could be useful for that sort of clinical circumstance where they're going to be going home anyway, right? So again, those are kind of the big differences you're going to find with that. And again, you can use these with local infiltration. You can use these as far as like epidural administration. You can use local blocks. It just depends on the type of procedure, kind of who you're working with and how they're using it. But the main goal here with these, a lot of times, is to reduce the amount of other analgesics that we need, right? So these tend to be opioid sparing. We don't need as much pain meds because they're just not sensing that pain that goes along with that. So again, looking at the absorption, right? So going back to the kinetics of these drugs here, a lot of it is going to depend on several factors. So for instance, the dosage that you're administering. Obviously, the more that you administer to, say, a local site, so say you're doing, say, sub-Q injection, the bigger the dose, the more likely you are to see systemic effects. And that's important because when we get to the side effects here, what kind of side effects would you expect to see with something like lidocaine? Say I injected too much lidocaine, all of a sudden it starts to kind of get absorbed systemically. What problems could I see? You can see arrhythmia, right? So essentially it could be bradycardia, it could be tachyarrhythmias, it could be lots of different things, right? And so what you're going to find is these are particularly cardiotoxic. And why do you think that is? Because they're blocking the same sodium channels they are in these nociceptive fibers. But again, we want our sodium channels to be working effectively in the heart because they need to beat appropriately, right? But you can see why dysrhythmia could occur here very easily by blocking the sodium channels. So anyway, so looking at dosage is important. Site of injection, certain areas are going to be more likely to have better blood flow or going to be more likely to see better absorption depending on that. Looking at tissue drug binding, obviously the tighter it binds to the tissue proteins, the more likely it is to stay local. Also look at the physiochemical properties of the drug, say how lipophilic it is, etc. Local blood flow, as I mentioned, kind of goes back to the site of injection, and then the use of vasoconstrictors. So using vasoconstrictors, what do you think that effect that's going to have on systemic absorption? Should limit it or increase it? Should limit it. Why? Yeah, decreasing blood flow, right? So the less blood flow is making it to and from the area. So because of that, you're having less transport of the anesthetic to other sites. So what's a common vasoconstrictor you might see in these local anesthetics. Epinephrine is the most common one, right? So if you ever see like lido with epi, if you ever see bupivacaine with epinephrine, that's what that is there for. It's to try to cause vasoconstriction. That's going to be important because one, that'll affect the dose that you can administer. So for instance, with lidocaine by itself, I can give maybe 5 milligrams per kilo as probably as a max dose. If I include epinephrine with that, then it bumps up to like 7 or 9 milligrams per kilogram that I can administer. So for particularly like large lacerations I need to numb up, or particularly large areas I need to inject with lidocaine, if I'm using epi, I can use more of it, which can be beneficial, right? What do you think are some problems of using vasoconstrictors? Some areas really need that blood flow, and if you decrease that, you can cause local tissue ischemia. So we'll talk about some areas where you do not want to use vasoconstrictors. There's a handy little mnemonic we're going to use to remember that. We'll talk about it in a second. You guys covered that already? What is it?
Nose, toes.
Fingers, penis, nose, and toes, right? So those are typically the places you do not want to use vasoconstrictors because that's where they're kind of getting terminal blood flow, and if you cut that off, you can cause tissue ischemia. Okay. In general, don't inject the penis. Like, it's just not a good idea unless you really, really need to. However, there are some occasions where you have to, right? Priapism, etc. Right? Anyway, we'll talk about urology later, though. But local anesthetics, as we mentioned, they're blocking the sodium channels there. Again, they work better on the more active the tissue is. So if you have an actively painful site, they're going to work much better in that tissue versus something that is maybe not in acute pain there. We're also going to find that things like having extracellular calcium can actually affect how well these are working. Things like changes in potassium can affect this. So just be aware that you can find different effects based off of things like electrolyte imbalances. This is clinically not that super important, but just know that things can change depending on what other kind of conditions are going on with the patient. Now, when you're applying this, again, we're going to find that you're, one, slowing the impulse conduction because they can't propagate the action potential. You're also going to be hyperpolarizing the cell because less sodium is flowing in, which means you're going to increase that threshold. So it's going to be harder to actually have that signal. Because again, when you numb up an area, if you're using an appropriate dose, is all sensation abolished? No, you can have still some sensation, right? Especially like deep pressure, things like that, you can still feel. But again, it makes it harder for those action potentials to occur there. Okay. And again, you're going to find that by inhibiting several of those sodium channels, again, you're just going to block total propagation there, and again, preventing that from ever getting sent up to the scene as the patient never actually aware of that pain signal in the first place. So as I mentioned, vasoconstrictors are good because they help to reduce systemic absorption. They probably reduce blood flow by about 30% or so. So that allows for me to have a higher tissue concentration of the anesthetic, so more of it stays right where I injected it. You also have lower systemic side effects, meaning I can give those bigger doses, right? So especially if I have a large area I'm trying to infiltrate with anesthetic, can be very useful there. But you'll find it's less effective with lipid-soluble agents. Why do you think that is? Those lipid-soluble agents are going to be able to just kind of dissipate out even further because they're across those membranes very easily, and so you're going to find this less effective. For more hydrophilic agents, it's going to work very well from that standpoint there. But again, most common you're going to run into is like lidocaine with epinephrine will cause that vasoconstriction. And so also you find less bleeding in the site as well. Why might that be beneficial? It makes it for a cleaner site, so you can actually get in there and do what you need to do. Your visibility is much better because the site's not actively bleeding potentially, or at least bleeding as much, and so you're able to get in there and make your sutures better, all that good stuff there. So those are additional benefits. Now, why did I mention cocaine has additional benefits of being a local anesthetic? It's a vasoconstrictor itself, right? So it will cause significant hypertension, tachycardia, because it's helping to stimulate the sympathomimetic system. That's why we liked it as well for especially like ENT procedures and things like that, because not only was it a good anesthetic, but it also was a vasoconstrictor. And so you kind of got 2-for-1 sort of actions there with cocaine versus something like lidocaine. I have to mix it with epi to get that additional benefit. Does that make sense? Okay. So anyway, so looking at this, we're going to find that the more highly lipophilic local anesthetics are going to tend to work faster because they're going to be interacting with the sodium channels more easily than some of the more water-soluble ones. You're also going to find that that potency correlates with lipid solubility. So something like, for instance, bupivacaine is going to be much more lipophilic. You're going to find use lower concentrations of it than you would lidocaine. So for instance, a common concentration of lidocaine, anyone know off the top of their head? What percentage? Like 1%, 2% lidocaine is a very common percentage. Versus bupivacaine, you might use, say, 0.25 or 0.5. Using a lower concentration because it's more lipophilic, it's much more potent because it can get in there and interact with the sodium channels. Now, what do you think that means for toxicity? It also means it's more potent to cause toxicity. So bupivacaine is a heck of a lot more scary if I were to, say, have an accidental IV injection of that than lidocaine would be. because once it gets onto the heart, it's going to want to stay there because it's so lipophilic, and that can cause severe significant dysrhythmias. And we'll talk about the ways we can help to treat that a little bit later on, but I want you to keep that in mind. Again, these are agents you typically do not want to use IV because you will kill that patient, right? Not only are you going to see cardiac issues, but you can also see CNS issues, right? Because those sodium channels are necessary to propagate those signals. So things like seizures are very common with these, right? Now, in some cases, you want to inject IV, like lidocaine, but it's under a very specific circumstance, right? You're using specific dosing for cardiac purposes. But any of these other agents, they do not need to use IV. So they're local anesthetics, not systemic anesthetics. Anyway, so again, things like lidocaine tend to be more water soluble. They're going to be less potent, so you're going to have to use larger percentages in order to get the same effect out of that. Okay, but bupivacaine, ropivacaine, these are good ones. We see these used a lot for like epidurals, caudal injections, local nerve blocks, etc. These are good, longer acting, lipid soluble. They work very well from that standpoint. So again, our routes of administration, we can do topical administration, right? So remember, like they have topical lidoderm patches. Again, that will allow for the drug to dissipate or to cross those membranes, cause local effects there. Again, where do we like to use topical lidocaine for? What kind of pain? And that makes sense, right? Neuropathic pains, deadening those nerves there. We know it's a nerve issue. That makes total sense there. I mentioned the injection is good for either the nerve endings itself. So for instance, if you had, say, like a hip replacement and you're doing a local nerve block, that's one way you can do it by working very locally. Or we could do it, say, for instance, in the epidural or subarachnoid spaces. That will allow for more diffuse activity, but for instance, if you inject an epidural space, it all depends on patient positioning and how far up the spinal cord the drug is getting to determine how far up that numbing effect is going to be. So for instance, when you go into labor, you'll typically get a usually fentanyl and ropivacaine epidural, and based on how the patient's positioned, you'll find that that level of numbness is going to be dependent on that, how far up the spinal cord is going. And again, you don't want to go all the way up to their neck, because again, you need them to be conscious, need them to be active and working with you, but just numb enough to kind of get the bottom half of the body, so that way they can not have so much pain associated with that labor. Does that make sense? Just something to think about. And then obviously IV, as I mentioned, you do not want to use unless you're using lidocaine for very specific cardiac purposes. Okay. So choosing your local anesthetic, again, you want to kind of pick it based off the duration of action required. If you don't need a long duration of action, something like lidocaine works very well. If you want something a little bit longer, like I'm going to be sending the patient home, I don't want them to be in pain later on when the lidocaine wears off, something like bupivacaine works a lot better from that standpoint, right? We're going to find some other cases as well where we can use short-acting ones. So for instance, we'll use things like topical local anesthetics for using it for needle stick analgesia, right? So again, if we have someone who needs to get IV placed, we can use topical anesthetics to try to numb up that area. Now, do I need that area to be numbed up for a very long time? No, because once I get the IV done, I'm done, right? So that catheter is not painful. It's just getting the initial stick. So I can use shorter acting agents there versus something like a laceration repair. You want something longer. So again, things with fast onset, fast offset can be good, especially for like short dental procedures, things like that. As I mentioned, long acting agents include like a ropivacaine, bupivacaine. Those are really good long acting agents there. So sometimes you'll find combination products that are available. So for instance, there's like a duocaine, which is lido and bupivacaine together. You may find that is additional benefit may kind of cover one another, where you get a little bit faster onset with lidocaine in some cases, and the bupivacaine will kind of a longer duration of action. Depends. And you also have one called Imla cream. So if you ever see Imla cream, this is a frequent topical product that we use, especially for like needle stick analgesia. If you have a patient who has like a central port in place, you need to access that. We'll use that occasionally. But basically what Imla stands for, and if you ever want to wow your preceptors with your pharmaceutical knowledge, you can tell them, oh yeah, it stands for the eutectic mixture of local anesthetics. You don't know what eutectic means? Any chemistry nerds out there? Basically means two things when they mix together, they lower each other's melting point. It actually gets lower, so that way they can go into solution a little bit easier. So for instance, lidocaine and prilocaine in some cases are solids at room temperature. By mixing them together, they go into solution. And so you can find that can be very useful when applying these, right? I don't want to say rub a stick of lidocaine on somebody, but if I have a nice cream I can apply to the area, that can be much more useful there. This is a good topical one, used again for that kind of local analgesia for needle sticks and things like that. Now, one of the things you want to know, if you ever have like a patient you're dealing with that have like ports in place or things like that. You want to tell them that these drugs take some time to kick in, right? Especially the topical administration is going to be a lot slower than if you're injecting it. So frequently, like our hemonc kids who have ports in place because they're frequently coming into the infusion center to get chemo, or sometimes our sickle cell kids, other kids like that who are getting frequent IV access, we let them know, hey, before you come into the ER, before you come into the clinic, apply this beforehand, like 30, 45 minutes, because otherwise, what oftentimes happens, and again, this is not great practice, but what will happen is the nurse, your kid will come into the ER, the nurse will say, okay, let me go ahead and we need to get an IV for you, let me go ahead and apply the Imla cream, they wait 5 minutes, and they go ahead and stick the kid. It's not long enough for that drug to really kick in, and the kid still feels the pain, right? So again, if you can, try to give them enough time for it to really kind of kick in, let it work, and then you're going to have much better effects there, okay? Because again, after that point, what is that patient going to say how well that drug works? It didn't work at all. Well, it's not that it didn't work, you oftentimes just didn't give enough time to kick in, okay? Does that make sense? Okay. All right, so toxicity, these are important points here. So looking at systemic effects, typically this is either maybe an inadvertent administration of, say, the drug IV. So maybe you meant to give it maybe subcutaneously, you gave it IV on accident, maybe the nurse hooked up to the wrong line, accidentally administered it. Or it could be local absorption after injecting it locally. Maybe you did too big of a dose, maybe the blood flow is too high and they absorbed it very well. So the big things you're going to find are going to be this direct neurotoxicity. Really, any of these nerves where the sodium channels are propagating the action potential are going to be affected here, right? So you can see a lot of neurotoxicity, and the cardiotoxicity is going to be the big thing we're going to see as well. So from the CNS standpoint, you can certainly see that by blocking propagation of these action potentials, things are going to start to slow down a little bit. So you can start to see things like some lethargy, some lightheadedness. One of the first things you want to note, and if a patient says this should be a warning sign, is they start to talk about a metallic taste in their mouth, or they start to feel like their tongue is getting numb. That's usually not a great sign, right? It usually means they're getting way too much systemically, and usually is a bad portent of things to come if you don't kind of manage that. Maybe stop either giving more of the anesthetic or whatever the case may be. But again, that can develop all the way into seizures potentially, which we know seizures can be deadly, right? And so again, there's things to watch out for. That tongue numbness and metallic taste, so those are the big warning signs you want to think about. So the other toxicities include the cardiovascular toxicities. You can see definitely that when bupivacaine, especially with that's kind of our classic one we think about, gets in and affects the heart, it will essentially stop it, right? Because if you stop sodium influx, you can't have an action potential. You can basically stop the heart cold in its tracks, essentially. And so again, bupivacaine is kind of classically known for causing more cardiotoxicity than most of the other ones, but really any of them could do it, right? You find this really broad QRS complex and then develop into ventricular arrhythmias and eventually asystole, as the case may be. So ways we can treat that is we talked about how bupivacaine is very lipid soluble. What if we gave another lipid compartment for the drug to partition into? And so there's actually some really good studies. If you ever go, if you look at, I'm trying to think of the website, things like Lipid Rescue, just Google Lipid Rescue and you'll find that toxicologist who was doing a lot of this research here. But basically what he was doing is he would take these hearts from an animal that was beating, he would administer bupivacaine to it, it would stop, and then he would administer intralipid. Intralipid is basically what we would use for IV fat therapy, right? So if you're giving total parenteral nutrition to a patient, and again, 3 big macronutrients are what? Carbohydrates, proteins, and fat. This is how they get their fat, essentially, right? If you're using IV nutrition. And so by giving this very fatty substance into the bloodstream, it allowed for the bupivacaine to partition off of the heart and into the intralipid. And all of a sudden, it was really kind of dramatic. If you read the case studies, you'll find that these hearts would stop after bupivacaine interacted with them. They administered the intralipid, and all of a sudden started beating again. And there's some really good case reports of patients who were actively coding after receiving something like bupivacaine inadvertently IV. Patients have been coded for 30, 45 minutes. They administer intralipid, and all of a sudden they come back to life like that. So there's some really cool case reports if you want to read those and get some extra, some nice drama before you go to bed or something, right? It's hard to describe a case report as dramatic, but like those are the really good ones, right? People normally, if you're coding someone for 30, 45 minutes, like they're not coming back. But these are really dramatic cases where they do. Anywho, so again, that's something that's really important to have available. So for instance, when we're starting up, say like a coddle or an epidural infusion of a local anesthetic, we'll always have orders for the intralipid available here, because it's very easy if you did not maybe place that LP appropriately to end up getting into IV administration. You may find that absorption is going to be too much, and you can see toxicity. So we always have orders for intralipid available for any patient who's on epidural with a local anesthetic in our hospital. You'll see that in most hospitals as well. Anyway, some other hematologic toxicities you can see here. This is a particular one with benzocaine. This is actually where we can induce a methemoglobinemia. Anyone know what methemoglobinemia is? What is that? It's where the globin gets met-hemed. Yeah, it's not so easy now, is it? Do you know? Not the heme is in the blood, but it has to do with hemoglobin. And basically what happens is whenever you have a strong oxidizer come aboard, you can actually end up changing iron. Normally it's in the ferrous state, it's in this 2+ sort of state here, and again, I'm trying to get back into the chemistry of it. But when you oxidize it, it turns into the 3+ state. Basically, you steal an electron from it, it turns into 3+. Now, normally, iron in hemoglobin binds to what? It likes to bind to oxygen, okay? And when we turn to this ferric state, guess what it likes to bind to? Actually likes to bind to water now. So by binding to water, you can't carry oxygen. That's usually not great, right? Because you can't deliver as much oxygen to the tissue. So if you ever see someone who is cyanotic, but they look like they're breathing fine, they're in no acute distress, this could be a sign that they have methemoglobinemia going on, right? Because they get very cyanotic, because that heme, which is normally red, ends up turning into that methemoglobin, and that is kind of bluish in color. And in fact, if you ever hear like a nurse who gets like a venous draw on a patient, they're like, man, this stuff looks really dark. It almost looks like chocolate. I would not advise eating it, but it has that appearance to it, right? Especially if you wipe it like on a bed sheet or something, like a white sheet, you can definitely tell the brown color. That could be a sign of methemoglobinemia. The reason why I mention that is because it's a very common thing you can see with benzocaine. Benzocaine is typically used as a topical spray, especially if we're like maybe getting an NG tube. We want to place for a patient, we'll spray into the back of the throat, so that way we kind of numb up their gag reflex a little bit, so that way they can get it placed and they're not trying to vomit on us, right? So normally there's instruction on there for how long to spray. Sometimes nurses get a little aggressive with it, and so they'll spray and spray, spray and spray and spray until like the can's empty, and they'll get another can, spray some more. Maybe not that egregious, but they spray a lot. And all of a sudden the patient gets cyanotic and they're like, oh gosh, what's going on? Check an O2 sat, still looks okay. The patient's cyanotic, usually not a good sign. It could be that methemoglobinemia because benzocaine tends to be a strong oxidizer there. So anyway, so as I mentioned, it's the most common thing. And again, you find benzocaine used for a lot of topical products as well, like Oragel. So it's a common, not common, but you'll see it where maybe a child is teething and you apply too much benzocaine to the gums there to try to numb them up for analgesia, and they end up developing methemoglobinemia due to that as well. What other patients are particularly prone to methemoglobinemia of a certain deficiency? Right, G6PD. So this is if you had a patient who had a G6PD deficiency you didn't know about, that could also be induced by that. So it's something to consider. Anyway, if you do see that occur, though, how can you treat it? You give a blue patient the blue drug to turn them pink again, right? So again, you give methylene blue, which is going to help to reduce that oxygen back from the 3+ to the 2+ state, and then it's going to be able to carry oxygen again, and then you're good to go, right? So it's something to think about there. All right, so there's two main classifications of local anesthetics. There's the amides and there's going to be the esters. And again, this is based off their chemical structure. To know whether it's an amide or an ester anesthetic, if there's an I before the cane, is an amide. Okay, so for instance, lidocaine has an I before the cane, so it's an amide anesthetic. We know just based off the name there. Bupivacaine has an I before the cane. Prilocaine has an I before the name. Okay, so just know that's an amide. Versus the esters have no I before the cane, so that way you know it's an ester local anesthetic. So for instance, cocaine, benzocaine, procaine, all those are considered to be ester anesthetics. And you're like, well, why would I care about if it's an amide or an ester? Anyone know? Does it have to do with their binding? It could have something to do with binding, but more clinically relevant is going to have to do with allergies. Because you can have someone that says, like, oh, I have an allergy to Novocaine, or I have an allergy to lidocaine. It's important because there is cross-reactivity amongst amides and there's cross-reactivity amongst esters, but if they have a reaction to one, they won't necessarily have a reaction to the other. So if I have someone who says, oh, I had a bad reaction to lidocaine before, I could potentially give them benzocaine, they would not have a cross-reactivity, okay? Because otherwise you may say, oh, they have a lidocaine allergy, I can't give them any local anesthetic. Well, that's not really the case. It's just a matter of figuring out. And again, the question whenever someone says they have an allergy is what? Well, what reaction did you have, right? You have to figure out if it's an actual true allergy you have to be concerned about or not, right? It could just be a side effect they're experiencing. It's like, oh, I got lidocaine one time, it made my fingers numb. Yeah, like, that's what it does, right? Where's it injected? In the fingers? Okay, that's how the drug works. But, I mean, sometimes people will get therapeutic effects confused with an actual reaction, right? So again, it's why it's important to ask. So looking at this, you're going to find that typically allergies are much more common to the ester class of drugs, right? So people are more likely to have a reaction to benzocaine or procaine or something like that. It's okay to use an amide in that case, right? You can switch them over to lidocaine or bupivacaine, and chances are they'll probably not have a reaction. Now, of course, you always want to use that with a grain of salt, because again, you may have that one snowflake of a patient who has a reaction to both. It's a possibility, but again, it's very unlikely based off this the cross-reactivity. And again, a lot of times people don't really know the difference between different agents here. A lot of times they'll just say, oh, I got Novocaine one time. And you really need to dig down to figure out which specific one they got, because a lot of people just say Novocaine to every local anesthetic, right? It's important to figure out specifically what they had there. Just like when you ask someone, it's like, oh, I took Tylenol. It's like, well, what kind of Tylenol? You know, did it have Benadryl in it? Did it have other drugs? You know, did it have Sudafed in it? Like all these different things you have to ask about. So again, just kind of a summary of looking at the kind of different clinical implications or situations you may use these local anesthetics. Lidocaine is kind of a good all-purpose. You're going to use it for a majority of things. It's nice because it's short-acting, so if it's a short procedure, you don't have to really worry about it sticking around forever. Good for topical use as well, so you're going to see that a lot, either as like a cream you can use for, say, like needle stick analgesia, as a patch you can use for neuropathic pain. Good all-purpose sort of anesthetic there. Bupivacaine, very long-acting. You see this used much more for things like epidurals, for local nerve blocks, etc. I remember when I was interning during my first summer out of pharmacy school, or I was between the first and second years of pharmacy school, I was interning at a hospital, and we had these, they're called on-cue pain pumps, and basically there are these big bupivacaine pain pumps. You filled them up, and they looked like a almost this weird kind of sphere, just full of drug. But they probably putting in close to like 500 mLs of bupivacaine, because the goal of it is to hook it up to the patient and go via continuous infusion, and the patient can go home, right? These things were so hard to fill up. I remember just like drawing up in a big 60cc syringe and just sit there and just squeeze it in. It took me like 15 minutes to get the stuff in here. It was so hard. So that's why I always think about bupivacaine pumps, how big of a pain in the butt they were. But not a pain in the butt for your patient if they're infusing there, because they are a good anesthetic, right? Bad joke. Anyway, just know bupivacaine can be very, very bad from a cardiovascular standpoint. And what are you going to use to reverse that if you have someone who starts coding? Intralipid, right? Intralipid is IV fat emulsion is the technical generic name for it, but intralipid is a drug we're going to use for that. Okay. Now again, anyone remember any other milky sort of substances we were using previously? Yeah, propofol actually comes in, it looks very similar to that. It's a very similar base that's going to be in against the lipid base. We'll not use propofol for that patient, but definitely intralipid itself. And again, that should be available really in any OR if they're using these local anesthetics, in the ICU units, things like that. Okay. Again, cocaine's used pretty rarely. Now, again, as far as controlled substances go, this is the only one that is a controlled substance. Anyone know what schedule it is? It's just C2, right? Very high abuse potential, but we do have acceptable medical uses. You may see it maybe occasionally at like an ENT office or for very particular cases, but again, clinically, we bought some, but we never end up using it. It's not used too commonly because I'd rather have the option of whether or not I need to include a vasoconstrictor or not, right? So again, it's nice if I can decide if I want Lido with or without epi versus cocaine. You're always going to get the vasoconstrictive effects, which is going to sometimes limit where you can use that potentially. Okay, so any other questions on that? Just remember where you can and cannot inject the local anesthetics into if they have a vasoconstrictor, right? So what is that mnemonic? Fingers, penis, nose, and toes, right? Anywhere you're getting that terminal blood supply, do not want to have a vasoconstrictor there, because you can cause it to get ischemic, get gangrenous, it's going to fall right off. Usually patients want to keep their nose attached, just don't make it fall off, okay? Anyway, let's talk about some sleep agents. Again, I'm not referring to my lectures. Yeah. So you were asleep for that joke, so there you go. I always like when students come back and they're like, oh yeah, I was studying for your stuff and I heard a joke you totally said and I didn't even catch it the first time, and it was hilarious. And I was just like, well, it's good if you laughed the first time. It gives me a little bit more validation, but whatever. Anyway, so sleep is a pretty frequent complaint you're gonna have patients come in with. It can be kind of troublesome, right? Because you know they need sleep, you know they need to, but a lot of the agents we're going to use for sleep, what's kind of the problem with them? A lot of them tend to be habit forming, right? You're going to find that patients ultimately will then need them to sleep, because what happens when you take these drugs away? You have rebound insomnia, right? So you're going to find it's kind of a tough problem with a lot of these agents, is that they are They tend to be habit forming. A lot of these are going to be controlled substances we're dealing with. You have to be careful with it. So the idea here is you want to use these agents for as short a period of time as possible, hopefully dealing with whatever underlying cause is of their insomnia, right? Now again, there's a lot of reasons for insomnia. You could have psychiatric disorders, psychosocial stressors like PA school perhaps, excessive alcohol intake. Now normally you think excessive alcohol intake would cause what? You think it cause sedation, right? Which makes someone go to sleep, and some people will abuse alcohol in order to help them sleep. But ultimately, you end up finding that it's not very good for having a good restful, continued sleep, right? It's not just a matter of getting to sleep; it's a matter of staying asleep as well. You can find some drugs are better for the initiation of sleep, some are better for the more maintenance of sleep and keeping someone sleeping, so they can get their full 7-8 hours, whatever the case may be, right? Also, caffeine and nicotine intake can be playing a role here, right? So if you slam a bunch of caffeine right before bed, are you gonna be able to go to sleep? I can't. I'm so laden with caffeine right now that it makes no difference to me. But someone like my wife, if she has a cup of coffee after like 2 p.m., she cannot sleep until like 3 a.m. or something. Like, it is incredible how sensitive she is to caffeine. Like 2 p.m., I was like, oh my gosh, like I can drink like a can of soda right before bed. Like, there's no problem with it. I mean, it's more a problem with me than her. But again, you'll find that some people just know what their caffeine intake is like and how it's going to be affecting them, right? So sleep hygiene. What is sleep hygiene? Like take a bath while you're sleeping? No. What's good sleep hygiene? How would you educate a patient on good sleep hygiene? Go to bed at the same time every night. What is the bedroom used for? Sleep and sex, right? Really, it's only two roles for. You should not be eating in bed. You should not have a big giant screen TV in front of your bed. Right? Whoops. Yep. A lot of people do not follow these recommendations, I'll guarantee you. You think about things like, people's phones and whatnot having that really strong blue light. That's why a lot of phones have moved over to using those, like the nighttime mode where it'll kind of yellow, because again, it doesn't stimulate the brain the same way as that really harsh blue light is. Like, one night my wife was like, I just can't get to sleep, and I walk in the bedroom and she's like blasting like the iPhone right in her face. I was like, perhaps this could be the reason why. She did not like that answer. Looking at things like avoiding daytime naps, exercising, etc. These are all things you should be recommending to patients. Obviously, from a substance standpoint, you want to make sure you're eliminating alcohol, caffeine, nicotine use prior to bedtime. But again, some people are really sensitive to that stuff, and like I said, coffee after 2 p.m. maybe no go for some patients, right? Also, avoid those liquids at bedtime because otherwise you're having to have them get up and go to the bathroom, etc. And again, think about your elderly patients, right? The more times they're having to get up in the middle of the night, it's dark. Maybe they have other medications on board that could be causing them to be a little bit more drowsy or cause some gait disturbances. All of a sudden they do what? They fall, they break a hip, and then have a whole slew of new problems, right? So things to consider. All right, any questions from the first half? All right, so we're talking about our sleep aids here. Again, our main goals are to try to correct any kind of underlying sleep issues that are going on there, right? Try to consolidate their sleep so that way you can get a nice restful sleep all the way throughout. Again, if you have a screaming 1-year-old that likes to wake up randomly, that maybe problem you can't necessarily get rid of, unfortunately, much as you've tried. I'm just kidding. Yeah. We always just a little funny aside. So we always joked, me and my wife, we have a little bit of a morbid sense of humor. We always say like, oh my gosh, we're just taking this kid to the fire station. We're just gonna take her. So we always joke. So now my older daughter is like really into like fire trucks and stuff, and so now I'm worried if I actually take her to see a fire truck at a fire station, she's gonna think, oh no, this is it. I'm done for. Going for adoption. No. Anyway. So, and our main thing here is to try to avoid adverse effects. Now, what do you think are going to be a lot of the side effects seen with these sleep aids, do you think? These are things that are going to make you sleepy, go to sleep, where the side effects are going to be. A lot of drowsiness, right? So again, this is going to be very dependent on the type of agent we're using, the duration of action, lots of different factors here, right? So things to think about. Typically, as far as the medication therapy, if once you've exhausted sort of your, no pun intended, your non-pharmacologic therapies, then when you have to use medications here, we want to use the lowest dose possible and for hopefully the shortest period possible. Because again, we know there's going to be physical dependence that's going to develop with this stuff, and so then when people get really, they develop a habit of taking these medications in order to get to sleep, and they try to come off of it, they need to titrate off slowly. Otherwise, there's going to be a lot of rebound insomnia seen with that. So you have to be really careful from that standpoint. Anyway, so looking at agents that people can get over the counter, and since there are over the counter agents available, and someone comes to you complaining of not being able to sleep, you want to ask what what have you already tried, right? You know, have you tried using Benadryl? Have you tried using Unisom? Because chances are they've probably tried using that before, probably tried self-medicating, didn't work, and now they're coming to you. And you don't want to make the recommendation of something they've already tried and didn't work. But first generation agents only, why is that? Those are the ones that are going to make you drowsy, right? Because they do what? They get across that blood-brain barrier, right? So Zyrtec, fexofenadine, loratadine, any of those are not going to be able to cross the blood-brain barrier. They typically do not make you very sleepy. However, the first-generation agents definitely do, right? So doxylamine, which is under the brand name Unisom most commonly, and then diphenhydramine, both of them are going to work just fine, right? They work pretty well for the most part, but just be aware of the other side effects you're going to see with that. So for instance, if I give first-generation antihistamine to an elderly person, what's that going to do to their mental status? It's going to make them mad as a hatter, right? So they're going to get those side effects from that, right? If they have constipation, what's it going to do? It's going to make that worse, right? If they have issues with urinary retention, maybe they have BPH. That's going to make that worse, right? So think about the anticholinergic side effects that go along with that, because these are not very clean acting drugs. They have a lot of multiple mechanisms associated with that, right? Other agents you can use occasionally include some antidepressants. So for instance, trazodone, as I mentioned before, was sort of a atypical sort of antidepressant, but it was able to cause a lot of sedation associated with that. And actually for a good long time, before nurse practitioners and PAs could write for controlled substances, this was really a good go-to prescription agent that you could write for that was non-controlled that would help with sleep. So I saw a lot of trazodone prescriptions that were going out. It may not be the case anymore because now you have that ability to write for controlled substances, but that was something I did see quite frequently. Other things that were non-controlled substances you could use include things like TCAs. So what are some examples of TCAs? Amitriptyline, nortriptyline, imipramine, doxepin, any of those are fine. And in fact, in some of those cases, for instance, like imipramine actually has a labeled indication for bedwetting, right? Why do you think it would be good for bedwetting? Because the anticholinergic, right, it'll dry the patient out. It's going to cause urinary retention. So we sometimes use that for children to try to dry them out a little bit, hold on to that urine for longer, so that way they could sleep throughout the night, right? They're not waking up because they wet the bed. So again, there could be some ancillary benefits for these medications. So you want to use them intelligently based off their mechanisms and based off what other kind of symptoms are going on, right? Why is the patient waking up? Okay, maybe I can use a drug to help kind of manage that. Again, these are good for patients with a history of substance abuse problems, because again, all the other ones we're going to talk about now, for the most part, are going to be controlled substances. Again, you typically want to avoid those for those patients because we do know that these are habit forming, could potentially lead to addiction in a lot of cases, or in some cases, right? So something to think about there. So some different agents we have. One here is called suvorexant or Belsomra. This is actually working through kind of a novel mechanism here that you don't see used too often. This is orexin A and B receptor antagonist, right? So orexin is a normal product your body produces here that helps to regulate sleep. Basically, this doesn't induce sleep. It won't cause you to go to sleep necessarily, but it doesn't it will actually turn off this wake signaling, right? So again, if your patient was maybe getting to sleep okay, but they're waking up too early, this could actually help them to stay asleep for longer, right? So this is good for more of that maintenance of sleep than necessarily it's going to be good for inducing sleep, okay? So again, this is how you can kind of tailor these therapies to whatever the specific patient issue is, right? So you want to ask, okay, well, are you having trouble getting to sleep? Are you having trouble staying asleep? What's the real problem you're having here, okay? And again, you're going to find that for a lot of these, somnolence is going to be the most common adverse drug reaction you have to think about, right? Also, some other things you can find, things like sleep paralysis. Not great, but again, it can happen rarely, but you want to let the patient know that, hey, this is a potential side effect that could happen potentially, right? So again, the brain's kind of woken up, but the body hasn't woken up yet, and so the patient kind of gets, it's pretty anxiety-inducing if you ever develop that. Narcolepsy-like symptoms can happen here as well. Again, this one's not used super commonly, but I just want to kind of show you what a kind of a different mechanism would be than just what some of our other agents are going to be, as we see here. So another one includes Remelting or Rosarum. This is actually a melatonin receptor agonist. Now, normally, what does melatonin do for us? Helps to regulate the circadian rhythm, right? So that way, when the sun goes down and it gets dark, our brain senses that, right? Remember that pineal gland, right? Remember that was responsible for helping with those sleep-wake cycles, and a lot of it has to do with the sun going down, sun going up, etc. So when you're blasting your face with an iPhone full of blue light, the brain is like, wait a second, is it daytime? Like, what the heck's going on here? So sometimes things like Remelting can actually help with this by helping to reestablish and regulate that circadian rhythm and helping with sleep onset. So again, if you have a patient having issues with sleep onset, this may be a good option here, right? And again, melatonin, you can use as an herbal supplement. I'm actually seeing a lot more kids are actually being placed on this nowadays. In fact, I will tell you that maybe like 2 or 3 years ago, I don't think I saw a single kid at our hospital using melatonin. Now we probably have like 7 or 8 in-house that are all getting melatonin, at nighttime. Some of them are getting pretty big doses to help with them with sleep. Again, should be is somewhat effective, but it's as good as a non-prescription, non-pharmaceutical product you can use potentially. Yes, sir.
Question, does melatonin affect the negative feedback loop since your body produces it?
It probably will affect it to some degree, but again, if maybe the body's not really responding to the melatonin that they're producing by helping to supplement it, you kind of overcome that. Again, this is not going to be as habit forming as something like, say, like a benzo is going to be for sleep, as we'll see in a little bit, but probably has something to do with the loop. But I don't know if it's going to necessarily disrupt it that bad. That's a good question for sure. But you can just supplement with more melatonin, or in this case, you're actually using something to directly agonize a receptor as opposed to giving them excess melatonin exogenously. So that's a good question. Again, this is not one you're going to see used super commonly, but again, it's good as a non-habit forming, non-potentially addictive sort of substance here, as we're going to see with some of our other agents. Okay, so these are kind of going to be your go-to sort of prescription-based drug products for sleep. And this is the most common set of drugs you're going to be prescribing for this, and are not like your over-the-counter diphenhydramine, Unisom, things like that. These are going to be your benzodiazepine receptor agonist. Now again, any benzo, whether it be alprazolam, whether it be triazolam, diazepam, any of those can be used for sleep, because again, what do? They make you drowsy, right? They're activating those GABA, or they're helping the GABA to work better. They're helping to open up those channels to allow what to flow in? Chloride to flow in. They hyperpolarize the cells and they slow everything down, right? So again, that makes sense why they cause sleep, or help to induce sleep. But you're going to find that with any of these benzodiazepine receptor agonists, I'll have a few new ones that we're going to kind of key in on here in just a little bit. They're all going to have FDA warnings for these complex sleep behaviors. Now, normally, you think of pretty basic sleep behaviors just lying there, motionless for 8 hours, right? What are some complex sleep behaviors? Those are where we get into things like sleepwalking, driving, make phone calls you're not aware of, sleep eating, common things, right? So actually you can find that for some of these benzos, that a common side effect is weight gain, right? Because the patient will not really be conscious, but they'll wake up, walk to the fridge, eat a bunch of stuff, and then go back to bed, right? Again, they're not really aware of it. These are things that can happen, right? Things to consider. Note that these are all going to be C4, Schedule 4 substances here, so there is some abuse potential. There's some potential for addiction. And again, they're definitely going to cause physical dependence. So people who are on these for a long period of time, they're going to have to wean off of it, otherwise they can't get that rebound insomnia, okay? They will help to reduce sleep latency. So again, it could have shorter time to actually falling asleep. So especially if they're having a hard time getting to sleep, this can be a good adjuvant to help with that. Okay. Now, why might you not want to use it for someone like a history of sleep apnea?
It'll suppress their respiratory system.
Yeah, it can actually suppress the respiratory drive, right? So even though their CO2 levels are building up, that's why people with sleep apnea, they'll kind of chronically build up those CO2 levels, and then all of a sudden, all of a sudden they start to breathe again. That CO2. If you suppress that with something like a benzodiazepine, they may not have that impulse and they can potentially die from that, right? So again, this is why opioids and benzos are really dangerous, and you're combining those, especially with patients with sleep apnea, okay? History of substance abuse, again, there can be a higher likelihood for dependence and addiction potentially. And then typically we don't like to use benzos for pregnant patients. If you remember, they're actually category D. We do not like to use those for those patients there, okay? And then especially avoid other CNS depressants. Alcohol is the most common co-ingestion with benzodiazepines. Again, you don't want to mix these together because they are very synergistic working together, okay? So, has anyone ever heard of the Ambien walrus? Yeah, so I've heard many stories of the Ambien walrus where basically these kind of refers back to those complex sleep behaviors. A friend of the family, my family, was taking Ambien, and all of a sudden they had all these Amazon boxes showing up to their doorstep. They had no idea why. And they go back to their Amazon order list, and it was like 3 a.m. They ordered like a bunch of stuff on Amazon. They had no intention of ever buying, and all of a sudden it's now on their doorstep. So there's a lot of weird stuff that goes on. You have to be really careful in letting people know that these things can happen, right? You may be sleepwalking, you may be sleep eating, you may be you may try to get behind the wheel of a car potentially. You have to know how these drugs are going to be affecting you, right? And also you're going to find that the longer the half-life of a drug you're going to use, if you Google Ambien walrus, there's some pretty funny comics there. But if you are using agents that have a longer half-life, what do you think is going to be the big side effect you're going to run into? Is it working for longer? What if it works for longer than 8 hours and you wake up? you're going to be pretty groggy, right? So for instance, if you had a big test to study for and you say, oh man, let me just go and take this Ambien, help me get to sleep, but then you wake up and you're like, oh wow, I'm still very sleepy, and you got to go take a test, that's going to be a problem, right? So daytime drowsiness is going to be a big problem with a lot of these, especially the longer the duration of action is. So if a patient only has an issue with getting to sleep, then a short-acting agent is good for them because it will help them to get to sleep, and then hopefully they'll stay asleep on their own. Sometimes if they have a hard time with initiation and also the maintenance of sleep, they need a longer acting form to help them all the way throughout the period there. So again, it depends on the type of sleep they're having issues with. And just be aware that the longer acting forms you're going to use are more likely to see that daytime grogginess when they wake up. Okay. Again, tolerance is going to develop over time, just meaning what? The drugs become less effective over time, may need to up their dose in order to get the same sleep they were getting before, but also it goes along with that physical dependence where they need to, if they're going to come off of it, they need to titrate off slowly, depending on how long acting the agent is there, because you will get a lot of that rebound insomnia. Now, we have a few that are considered non-benzodiazepines. We call these the Z drugs. These include zolpidem, zaleplon, and then S-zopiclone. The brain anterior Ambien, Sonata, and Lunesta. These are GABA A agonists, so these are kind of working on a little bit specific subunit there of the GABA A channel. They work just like the benzodiazepines though, but these ones are specifically marketed for sleep. Some of them you may find have a controlled release preparation that has a little bit longer duration of action. It's better for more maintenance of sleep. But again, those are the most common ones you're probably going to run into that are marketed specifically for sleep. But just know that any of the benzos can work for helping to induce drowsiness. And so here's just an example looking at some different options here that you have for managing these patients, helping them with their sleep. And so you notice here that things like the half-life are going to be playing a big role here. So for instance, for helping to induce sleep, do I want something that's going to have a 39-hour half-life? Probably not, right? Now, the patient may get tolerant to those effects over time, and so especially if they have a job and they're having a hard time sleeping, when would you want to initiate therapy with this, do you think? Probably on the weekend, right? Because again, if they have a little bit of daytime drowsiness on a Saturday morning, that's not going to be as big of a deal as if they have to wake up on Monday and go to work, right? So these are things you want to consider, like when to actually start the med, maybe dependent on what their situation is like, right? And you can just know that, especially like in older patients, they may have a hard time with the metabolism of these drugs and the excretion. So shorter acting, water soluble drugs are going to be better for those elderly patients. You guys remember the benzodiazepines that I said are good for elderly patients? LOT. Remember, what does that stand for? Lorazepam, oxazepam, temazepam, triazolam is the other one. Yeah, so those are the four big ones that are water soluble. They don't have active metabolites. They're going to have good activity there in the elderly patients, as opposed to something like diazepam that has a lot of active metabolites and hepatic conjugation, all that kind of stuff, right? So again, just things to think about. And how would I reverse these if I had someone who took too much, say Lunesta or Ambien? How would I fix that problem? I can't do anything. I just have to let them sleep it off and maybe intubate them. Flumazenil will also work for these as well, right? You may not see they work quite as well, but for any benzo acting drug, even if it's a non-benzo specifically, because again, benzodiazepine just refers to the structure of the drug. Any of those are going to be able to work for, flumazenil will work to help reverse those effects there, okay? But again, as someone who's chronically taking Lunesta for sleep, and all of a sudden I give them flumazenil and I reverse that, what's going to happen? You can have withdrawal symptoms, right? Maybe seizures in some cases, but they're definitely have withdrawal symptoms. Okay. Sorry, I accidentally hit the pause button. So, anyways, let me repeat that real quick. Just know that modafinil, armodafinil are good for shift work disorder when you want to stay up all night and then you want to sleep during the daytime. These are stimulants that you're going to take as you start your work shift in order to keep you awake during that daytime or during that nighttime, so that way you can sleep during the day. It's also good for narcolepsy, help keep you awake so that way you don't randomly kind of fall asleep. And again, these are more stimulant agents. These are not actually going to put you to sleep, okay? And they're controlled substances. Okay, so any other questions on that section? If not, let's move into the endocrine section.